Welcome to Clinical Reasoning Rounds, Episode 5. Today, we step away from labels and look at the most common yet misleading complaints in medicine. Always tired, swollen legs, sudden diarrhea, breathlessness, and a lingering flu. Each one holds a secret. Let's see what's behind the doors. We follow our standard 6-beat rhythm: history, examination, investigations, and then the critical moment. You decide. I'll pause, you commit to an answer, and then we reveal the reasoning and the pearls that define the case. Say your answer out loud before the reveal. That's how patterns stick. Here is our board for the round. 5 patients, 5 complaints, and absolutely no specialty guidance. From the man who can't stay awake to the 62-year-old with a flu that just won't behave. We are starting with the facts exactly as they arrive at the clinic door. Case 1. A 55-year-old man who can't stay awake. 18 months of deepening fatigue, falling asleep at his desk, and 8 kilograms of unexplained weight gain. Fatigue is the most common complaint in medicine. The list of causes is huge, so we need to listen closely to the details. Let's break down the history. He sleeps 10 hours a night but is never refreshed. Depression is a possibility, but his sleep is long and unbroken, not the early morning awakening seen in classic cases. He has constipation and weight gain, and his brother has type 1 diabetes, pointing toward an autoimmune history. Examining him confirms the trend. Everything is running slow. Pulse is 56. The skin is dry and scaly, and there is subtle proximal muscle weakness. His whole system is idling below speed, like a dial has been turned down. Now let's look at the labs. The blood work shows 3 quiet flags: mild anemia, a slightly high creatinine, and elevated cholesterol. None are dramatic, but they align perfectly. One gland regulates the body's metabolic idle speed. When it fails, everything follows suit. Which gland are we looking at? Pause the video now. First, name the diagnosis and the single blood test that proves it. What will the result look like? Second, why is this likely not depression? Use the history we've laid out to argue against that diagnosis. Commit to your answer before we proceed. The diagnosis is primary hypothyroidism. The high TSH proves the pituitary is working hard to compensate for the thyroid's failure, which is likely autoimmune in origin given his family history. The thyroid hormone affects every organ, which explains the systemic slowing we observed. Remember the classic signs: the dry, scaly skin, the malar flush, and the delayed relaxation phase of the ankle jerk. His numbers were also telling a story. Renal underperfusion, not kidney disease, caused the creatinine change. This is the full portrait of a system lacking thyroid hormone. Treatment is simple: daily levothyroxine, but go slow, especially in patients with heart disease, to avoid unmasking ischemia. The key takeaway: always include the thyroid in a fatigue workup. Fatigue, weight gain, and a slow pulse is a classic pattern. Let's move to our second case. Case 2, a 72-year-old with massive swelling. 10 kilograms of water weight gained in just 3 months. He also mentions his urine is frothing. When we see generalized edema, we must narrow down the source between heart, liver, and kidneys. Let's examine the evidence. His history reveals a flood of fluid. The most striking detail is the frothing urine, a sign of heavy protein loss. He also reports spontaneous bruising, which might seem unrelated now, but we will revisit that later. His past medical history includes heart disease and heavy smoking. The physical exam maps the fluid well, showing edema everywhere from his ankles to his face. However, his heart and liver appear relatively normal, which helps us rule them out as the primary culprits. But take note of that bruising around his eyes. It's an unusual witness. The lab results clarify everything: low albumin, heavy protein in the urine, and significantly high cholesterol. This is a classic triad that points to a specific organ's filter failure. If the heart and liver are innocent, the answer lies in the kidneys. Let's look closer. Pause the video. This one has 2 layers. First, identify the organ causing this fluid overload and name the syndrome. Second, explain the significance of those periorbital bruises in the context of his normal clotting. There's a specific disease behind these signs. Name it and the test that confirms it. This is nephrotic syndrome. The kidney is leaking protein, which drops blood albumin and lets water escape into tissues. The liver responds to this loss by ramping up lipid production, explaining the high cholesterol. The heart and liver are innocent here, confirmed by his physical findings. Always dipstick new edema. The culprit is amyloidosis. A clone of plasma cells produces misfolded light chains that deposit in tissues. These deposits silt up the kidney filter and make vessels fragile, leading to the classic periorbital bruising. Diagnosis is confirmed by renal biopsy and immunofixation. It's a systemic condition that requires focused management. Management involves fluid control and statins for lipids, but don't forget anticoagulation. Nephrotic patients are hypercoagulable. Chemotherapy targets the underlying plasma cell clone. Remember, bilateral edema requires an alibi for the heart, liver, and kidneys, and periorbital purpura is a high-yield clinical pearl for amyloidosis. Case 3. A 74-year-old woman admitted for diverticulitis. She was treated with antibiotics and seemed nearly ready for discharge, when suddenly, diarrhea struck. In medicine, we know medications can be the start of a disease. This case explores how a cure can inadvertently trigger a new crisis. The timeline is key. She received broad-spectrum IV antibiotics for diverticulitis. On day 5, she developed watery diarrhea. Consider her profile: 74, in a care home, and on a proton pump inhibitor. These factors create the perfect environment for an opportunistic pathogen to take hold in her colon. Her exam shows fever, dehydration, and tenderness. Most concerning is her creatinine, which is climbing, a clear sign she's losing fluid volume faster than she can replace it. The combination of recent antibiotics, new diarrhea, and a rising white cell count points directly to one specific diagnosis. Pause the video and answer these questions. First, what is the likely organism and why was she specifically vulnerable? Think about her age, environment, and medications. Second, this condition is graded by severity. Which of her current findings indicate a severe grade? Commit to your answers now. The diagnosis is Clostridium difficile colitis. Antibiotics destroyed her gut's healthy flora, allowing C. difficile to bloom and release toxins. Her age, care home residence, and PPI usage all lowered her threshold for infection. Diagnosis is confirmed via stool toxin testing or visualization of the colitis. Severity matters because it dictates the treatment. With her high fever, elevated white count, and rising creatinine, she meets the criteria for severe disease. The severity ladder helps clinicians decide between oral metronidazole for milder cases and oral vancomycin for more severe presentations like hers. Management requires immediate isolation and strict hygiene, as spores are stubborn. We must rehydrate aggressively and target the infection with oral vancomycin. Watch for complications like toxic megacolon. Ultimately, this case highlights the importance of antibiotic stewardship. Prescribe carefully to protect the internal ecosystem. Remember these pearls. Always suspect C. difficile with new diarrhea in hospitalized patients, especially after antibiotic use. Understand the risk profile: elderly, institutionalized, and those on acid suppression. Finally, view every antibiotic prescription as an ecological intervention. Let's move to our fourth case, a young woman with cardiac distress. Case 4, a 23-year-old student who was very fit until 2 weeks ago. Now, she is breathless after just 50 yards. She had a flu-like illness recently, but while the fever faded, the breathlessness has steadily worsened. A young person facing heart failure is a call to be extremely vigilant. Her history shows a clear decline. The prodrome of a flu-like illness followed by progressive breathlessness and palpitations is a warning sign. She denies substance use, but we must ask, as direct toxicity to the heart can mimic this presentation, what could be the underlying cause? Her exam reveals a heart in trouble, a racing pulse, low blood pressure, and a raised JVP. A third heart sound is a red flag in a young patient. Most notably, her pulse is disproportionately high compared to her mild fever, pointing toward an inflammatory process specifically affecting the heart. The investigations provide the smoking gun. We see global T-wave flattening, not a restricted regional pattern of a blocked artery. The chest X-ray shows an enlarged heart and lung congestion, confirming heart failure. The question isn't just what, but why. We have a young woman, a prior viral infection, and a struggling pump. Let's look closer. Pause the video. I want you to connect the dots. First, what is the diagnosis, and how does that flu from 2 weeks ago explain today's heart failure? Second, name 2 dangerous mimics you must exclude when a young patient presents with these symptoms. There are clues here that separate a common illness from a true crisis. The diagnosis is viral myocarditis. The virus did not just cause a fever. It invaded the heart muscle itself. This is an inflammation of the muscle, distinct from the pericarditis we discussed in episode 1, although they often coexist. Remember the hallmark: global ECG changes and tachycardia that exceeds the fever's heat. Proving the diagnosis involves measuring cardiac enzymes like troponin and using imaging like an echocardiogram to show impaired function. Cardiac MRI is the gold standard for visualizing the inflammation. Treatment is about rest, strict, enforced bed rest, to let the muscle heal, alongside supportive care for the failing pump. 3 pearls. Any young patient with new cardiac symptoms after a viral illness has myocarditis until proven otherwise. Look for the disproportion between pulse and fever. Finally, follow these patients up, as some can progress to permanent heart failure. And now, our final case, a 62-year-old with a flu that behaves very strangely. Case 5. A 62-year-old man carried into the ED. It started as a classic flu, aches and fever, but by day 4, the script flipped. He developed a dry cough, confusion, and worsening breathlessness. Flu usually crests, but this man's illness is clearly on an upward, dangerous trajectory. Walk the timeline. Days 1 and 2 were standard malaise and rigors, but day 4 brought the turn: breathlessness, confusion, and diarrhea. He just returned from a coach tour of Spain and Portugal, staying in hotels. Remember, when evaluating a mystery fever, always ask where they have been, and specifically, where they stayed. His examination is grim. He has central cyanosis, oxygen levels of 86%, and a respiratory rate of 32. His lungs show diffuse crackles, and he is disoriented. This isn't just a respiratory infection. It's a systemic attack. Look at the danger markers: hypoxia, confusion, and high fever. Look at the chemistry: severe hypoxia, low sodium, and low calcium. His white cell count is surprisingly near normal, but his lymphocytes are crashed. His urine shows blood and protein, suggesting renal involvement. This is an atypical pneumonia pattern, diffuse lung infiltrates, not lobar consolidation. The fingerprint is distinct. Pause the video one last time. What is the diagnosis, and which specific organism is responsible? Connect his travel history to the cause. Next, identify the findings that mark this as severe pneumonia. What rapid diagnostic test would you reach for to confirm this before the culture results return? The organism is Legionella pneumophila. It thrives in warm water systems like hotel plumbing. His tour exposure was the catalyst. It is an, quote, typical pathogen, meaning it breaks the standard rules of pneumonia presentation, such as the building prodrome and the multi-system organ damage we saw in his kidneys and brain. Severity is measured by specific markers like confusion, high urea, and elevated respiratory rate. He hit these targets, necessitating high-dependency care. You must cover for atypical organisms using antibiotics like clarithromycin immediately. Legionella antigen testing in the urine is your rapid, reliable best friend for naming the bug fast. 3 pearls. Any flu that adds confusion, diarrhea, or doesn't resolve by day 3 is not the flu. Second, recognize the atypical fingerprint: diffuse infiltrates plus low sodium. Third, when pneumonia is severe, start atypical antibiotic cover from the first hour. Your method is what protects the patient. Here is our summary board: 25 patients, 5 episodes, and 1 common theme. Look beyond the surface. From thyroid-driven fatigue to hotel-acquired Legionella, the differences were found in our method of history, examination, and laboratory reasoning. Keep this board for your future rounds. Rounds are complete. We have decoded 5 common complaints through careful clinical reasoning. Remember, your method is your strongest tool. New unsorted cases will arrive next time. Bring your diagnostic focus. For education only, not medical advice. See you on rounds.